Hello, and welcome to another episode of Cutting Edge Health. For those of you who are joining us, my apologies if you're joining us live. We were supposed to start a few minutes earlier. Unfortunately, I got caught up with some patient care duties. So let's get going. Today, we're going to talk about shoulder pain. And one of the things that is listed as this title is, do you think shoulder surgery is your last option? What if we can offer you another one, something else, instead of you having to go immediately to shoulder surgery? If we haven't met, I'm Dr. Orlando Landrum, a physician who's trained in anesthesiology and pain management, but what we predominantly do is interventional orthopedics and interventional psychiatry, meaning we help people be able to be physically functional without pain and be able to decrease maladies that impair mental health and functioning. So today, what we're going to talk to you about is how to be able to deal with shoulder pain in a different way. Most people know that shoulder pain affects about 30% of the US population. Sometimes it's secondary to trauma or events that take place, but many times it's through quote unquote degenerative disease type things, or wear and tear is another way to kind of express it in sort of layman's terms. So frequently you have an x-ray that shows up, looks something like this. You pop up and you see an x-ray and you say, oh, okay, the thing on the far left-hand side of the screen is that arm bone or humerus, and then it goes into a socket, and we hear some mumbo jumbo and we're like, well, what the heck is this? So what the heck that is the following. So explaining it in detail is you have the shoulder and it sits in a socket, or the humerus, and it sits in a cup. The cup is different, however, than what you have for your hip. Your hip has an actual significant cup. So if we were really trying to utilize something like that, it sits into an area where it fits with the areas that surround it with some degree of facialness that holds it in place so it can pivot. When you look at the aspect of the shoulder and how it sits in its own cup, even looking at this x-ray, it's much more shallow. That shallowness has a number of things that are associated with it. Specifically, the thing is that shoulder can be moved outside of the area of the cup. In other words, a dislocation, as many people have heard of, right? Well, the thing that actually sits around that shoulder is nerves, and those nerves are plentiful in nature. And so some of those nerves are things like the following. If you were to take a look, you can see this yellow line right in the middle. It forms this network that surrounds the other area of the shoulder. If you're taking a look at this picture, you can see the collarbone or the clavicle. You can see the deltoid, which is that muscle that's kind of that cap that sits over the area of the shoulder. And those nerves that come out and innervate different muscles is something that's called the brachial plexus. And that brachial plexus provides innervation, or in other words, nerve supply to portions of the neck, to portions of the shoulder, portions of the arm, even distal further down into their portions of the arm. And so we utilize this to our advantage to be able to treat. Many people have actually had injections into the shoulder. As a matter of fact, as a physician, I just did a shoulder injection earlier today, using ultrasound to be able to go after different parts of the shoulder. The most common way of doing it is probably blind, and it's a posterior approach that's trying to just get into the joint itself and give quote unquote steroid, or cortisone is what some other people would use to kind of label that. The downside behind doing an injection like that is the following, is when it's injected just into the joint, steroid itself, although it provides an anti-inflammatory effect, meaning it decreases inflammation, it can be able to decrease pain that's associated with it. It also has a degradatory effect, meaning it can break down the cartilage. So you have this seesaw effect of making the pain go away for a short period of time, but causing long-term damage that hastens the pain's return and probably makes that medication less efficacious, or in other words, meaning it doesn't work as well as what we otherwise would think over a period of time. So fancy words, right? But what I want people to really kind of understand, particularly on this channel, is we want to be able to emphasize what are your options and how you should be, in essence, an informed patient, and in some ways, even an informed consumer. It shouldn't be that you get 3 options and that's it. It should be a discourse. It should be a conversation that what we hope to do is empower you to add other things to the table that may be of benefit to you. And what I mean by three things is normally patients come in and say, hey, I have shoulder pain. It's bothering me. Fine. I'm going to get a pill. Or you know what? The pill doesn't work. Then I'm going to get a cortisone injection. Cortisone injection, that means that it doesn't work. Then that means I must have shoulder surgery. And I'm going to try to stay within the realm of appropriateness for YouTube so I don't get dinged. But you can probably gather that's not the full extent and spectrum of different offerings that exist. On the channel, we've talked about things like regenerative medicine that talks about using autologous cells in your own cells to be able to improve healing in various different ways. We've talked about things like traditional neuromodulation, which to be able to kind of break that down basically means spinal cord stimulation or peripheral stimulation that can be able to provide treatment. But today, what we're going to really kind of focus on is how to be able to target those nerves and how to target those nerves on the short term. What many patients will say to me is, yeah, doc, I hear what you're saying, but is this covered by insurance? And what we're talking to you about is an insurance offering and therapy that's covered by the vast majority of insurances. The question is, does your doctor know about it and can they do it, right? So let's talk about what that paper happens to be. And that paper is the following: the utilization of radiofrequency techniques for upper extremity pain management, okay? The paper itself was actually published and done in the aspects of the Middle East and Saudi Arabia and such. But be that as it may, what it does is it takes and pulls data and looks at radio frequency, the various different types, how it is efficacious compared to treatment options like steroid injections directly into the shoulder. And as a matter of fact, we have another 3 other papers to be able to utilize to supplement this as well. What I want to do, though, is to make sure that people are understanding, but you also have resources. So the people who watch this channel range in understanding from newbies who are just kind of getting an insight into like how can they take control of their healthcare, to people who have really been well-versed or well-read and quite literate in understanding what are the different options are. So I want you to be able to have something for everybody if we can, okay? So let's kind of go back and talk about this radio frequency that you saw in this title. So for those of you who have followed us before, we've explained what radio frequency happens to be. It's interesting because I see a number of channels that exist in regenerative medicine that just really, for lack of a better way of saying it, they just dog regenerative medicine, rather radio frequency. They say regenerative medicine is the ultimate thing. There's nothing else that can be able to potentially give you benefit. And these other things are just terrible. And my sentiment is the following, right? I kind of think regenerative medicine does provide value. There's no doubt about it. And the vast majority of time, it doesn't make things potentially worse. However, the fact of the matter is, if we really speak in real and honest, not everybody has the means to be able to pay for a regenerative medicine treatment. Now, I can give arguments as to why they should save or whether they should consider other financial options to be able to do so. But those people who, even within that context, can't do that, what the heck are they supposed to do? Just take the 3 options and say, oh, well, let me rub my butt and get glad? No, I don't think so. I think what we need to do is to say, okay, let's make our patients informed and talk about what are the downsides to radio frequency, how we can use that as a bridge therapy to do other things, maybe even being able to use regenerative medicine after we do radio frequency. And there's reasons for why we would consider doing that as well. And if not, are there other therapeutic options in lieu of surgery, but that sit in between radio frequency and not? So to repeat that in a little bit more down to earth fashion, basically, regen is great. Regenerative medicine, it uses different things like PRP, platelet-rich plasma, and stem cells to be able to help improve the healing of the joint and mainly be able to improve not only its function, but it's also its ability to be able to move and to be able to decrease pain. But it's not covered by traditional insurance. So normally, you're going to have to find other mechanisms to be able to pay for it. Radio frequency has historically been covered by insurance, traditionally within the areas of the spine. And we have a number of videos on this channel that talk about it. But at the end of the day, what it really is that you apply heat to an area that has nerves that are sensory in nature. So what that means is those nerves, their main function is to tell you this area hurts and has pain, but it's not as involved with the areas of motion. Now, notice I have qualifiers in those statements. Basically, what I'm saying is that there are certain mixtures of nerves that do have motor components. They have something that's called proprioception, which means it makes the body aware of where it is in space. And sometimes when you do a radio frequency, it impacts that. But the vast majority is able to decrease the pain presence and be able to improve the person's functionality, right? So let's get to the kind of context of how is this working within the aspect of the joint, and specifically what does this paper talk about? So we take a look at the paper. Basically what it does is it does the following, is it references how long has radio frequency been in use. And to be quite frank with you, radio frequency has existed much, much earlier than the 1990s. I want to say it started back in the 1930s or so, but the aspect of radio frequency has really kind of come into its full evolution, specifically within the aspect of the 90s. And what they found is that it was able to provide, as stated, this pain alleviation that didn't result in neurologic harm. Now, again, what does that mean in layman's term? Is that it can help improve pain and it traditionally doesn't cause a nerve problem. But there's some context that we really need to kind of get into so you are really understanding of what are some of the other things that are come along with this, right? So what they basically suggest is that joint pain, which can be caused by a number of different things, which we won't go into detail in this video, but we'll explain in some other videos how and why you feel the pain, can be mitigated or be able to be treated by using radio frequency. So what they did is this particular paper I referenced earlier, it looked at 129 studies, and it found of the different criteria that 99 fit the criteria. And we can go into details about it, but basically they took and pooled 100 studies that looked at radio frequency of the shoulder and tried to assess, did it make sense? Okay. And if for those of you who are well-versed in science, it's something that's called a meta-analysis. If you follow our channel, you know we utilize this a lot. And in essence, the reason why we're doing this is because it helps us take the best minds and say, okay, all these people found these different results. What was the vast majority consensus? What did most people find made sense, right? And so what it really came out to be is those 99 studies that they found, they were able to say that radio frequency provide a promising, minimally invasive procedure for controlling upper extremity pain. And they've also started looking at whether there might be some value in the elbow and wrist. So the elbow and wrist are a little bit more complicated, and we'll cover that in a different video. So for those of you who have interest in that, please check us out. If you think that this might be something that's of use, maybe even subscribe to the channel if you think that it's useful to you or someone you care about. The elbow and wrist are a little bit more complicated because they're narrower, tighter spaces, and those nerves are not just all sensory. They have some motor function that we have to be really particularly well aware of. So it goes on to talk about radio frequency in the history. As I mentioned earlier, it was first listed as neurotomy or rhizotomy, which are other different terms, and described by a doc who originally utilized it in 1931, as I stated before. When we talk about it, we talk about shoulder pain, and as mentioned, it's prevalent in about 30% of the United States population. It's really common, so 1 out of 3 people, and it can be because of degeneration through trauma or overuse. So when we talk about RFA, it's normally targeted to the nerves in and around the shoulder. And this is where things get a little bit more involved. And we're going to explain to you, what do I mean by more involved? If you're getting value from this, maybe hit the like button and let me know that this is working for you. But in essence, it's a treatment option that targets it by doing 2 things. For those of you who are familiar with radio frequency of the lumbar spine, thoracic spine, or cervical spine, you know that initially we do local anesthetic, something that is called a medial branch block. And the reason why it's called a medial branch block is the nerve that comes from that area of the joint is the medial branch of that specific nerve that innervates, or the nerve that supplies that area of the joint. For this, there's a whole host of different a whole host of different nerves that are present. Again, thank you, Elaine and Robin, for joining us live. For those of you who are catching us at a later point in time, if you have comments, please leave them and we'll see what we can do about trying to get back to you. Okay, so I'm going to show you a few pictures. Those pictures might be a little bit intimidating at first, but hang with me. I'm going to kind of explain to you what it is that we got going. So if you take a look at this picture, different from our previous picture that looked like just a simple x-ray, here we got the shoulder bone, meaning the humerus on one side, and then we have that little cup that comes off by the scapula or shoulder blade. When we look at the cartoon picture, we can kind of see that same thing. We see the humerus on that one side over here, and then we see that little cup that's connected to the shoulder blade or scapula. And then we have all these yellow squiggly lines that just seem to be coming from everywhere. Well, these yellow squiggly lines, as I'm sure you guys have probably already gathered, are the nerves that supply the joint. And it's quite a few nerves, as you can kind of see. So you have things like the suprascapular nerve, you have areas like the axillary nerve, you have areas like the lateral pectoral nerve, and they're all fancy names. But at the end of the day, there are ways for us to be able to target this nerve supply by placing needles at the site and then allowing that treatment to be able to improve pain. So another pictorial representation of the following. You can see this needle that's coming in towards the suprascapular nerve, and we're able to stop that nerve from complaining. So most people would say, well, but how do you find out where the nerve is? And that is the crux of the problem. And it's a very good question, right? But as he just stated, I'm just getting warmed up. So historically, when we looked at this, what we normally would do would be something like fluoroscopy. So if we were talking about it, we would talk about radiofrequency and how to be able to kind of utilize it within the context of mainly X-ray. And so that's what this particular paper is. You may not be able to see it in depth and detail, but it actually referenced that, right? But then we started looking at papers like the following, where they looked at the components of neuromodulation. Pardon me, it's this paper is what we want to add. It's cooled radiofrequency specifically for the area of the hip and shoulder. And what it did is it looked at fluoroscopy in combination with ultrasonography. So using both X-ray and ultrasound. And so, as mentioned before, normally you get a few different options. Well, do some physical therapy, some medication, some weight loss, do intra-articular injections of steroid or cortisone, or get a hip or shoulder replacement, right? That's what this paper is kind of going through and summarizing. But then you can see this particular paper uses a specific type of radiofrequency. So without going into too much detail, but for those of you who are interested, please hit me up in the comments and we'll be happy to kind of explain to you. There's three different types of radio frequency. One type is something that's called thermal. It's the most common and it's traditionally covered by insurance. The second is something that's called cooled radio frequency, which is similar to thermal. There's different context of it, but in the end of the day, it can allow for a more robust target in terms of the distribution of heat that's applied without causing damage to other important structures. And then there's something that's called pulsed. And pulsed is a decreased tissue, and it basically affects the nerve in a physiological way that's different than traditional thermal. It traditionally has problems with coverage for insurance, but when we start thinking about pulse utilization, we can consider how that might give us benefit, particularly when we start to look at the spectrum of what happens after we've been able to improve this. But now we want to say, what do we do next? And how can we combine those with maybe a regenerative treatment possibly in the future? Because we're looking to figure out how do we leverage. Now we know where the target is. We know what the result is. Now, what else can we be able to do that may be able to be more sustainable? So this particular machine is kind of one of the first context of cooled radio frequency before. Without going into depth and detail about it, we're going to kind of show you what the next utilization is. And in essence, what it did is, as you saw in those other pictures from before, it showed the shoulder capsule over there on the top left-hand component with the nerves that innervate the area of the shoulder. And it shows the posterior component of that where you actually are able to get after those nerves. This pictorial representation shows it with a more prominent degree of imaging, which we normally wouldn't utilize. But then as we can take some understanding, we were able to say, where do we place our needles? And this technology is not new. our own practice has been doing this probably for the last 7 to 8 years, but it's not commonly widespread. And there may not be that many docs that are utilizing it, but you can find people who can provide value. Let me take a quick segue for a second, and pardon me for just one moment. What I do want to kind of tell you is that this does not just have the function of being able to prevent people from having shoulder surgery alone. It has other values too. And the value that it does also have is the following. And I am excited to be able to kind of explain it to you, is many people can't qualify for surgery. And what I mean by that is they have other medical problems that don't let them have surgery, whether they have a lung issue, a heart issue, they have pathology that has affected the shoulder. This can be useful even for those people that have had previous problems with actual replacement and still have a nerve issue that's giving them a problem, right? So when we talk about what can we do, this can be able to provide value, right? And so what it goes on to talk about in this particular paper is cooled radiofrequency. It shows you both in cartoon formulation as well as an X-ray where the needle placement happens to be. But then it shows you what is the position of the patient, because we do both an anterior, or meaning from the front, and a posterior, meaning also from the back, in order to get all those nerves that are in play. So there's different areas of the outer portion of the arm. There's different portions of the inner portion of the arm. There's different portions of the back portion of the arm. And although it sounds like it's a lot, it's a pretty facile, easy procedure to get to. This paper also goes into some of the aspects of the hip, which we're not going to cover in this context. But as we kind of scroll past this really quickly, one of the things that it goes on to do is it talks about how to be able to do treatments that aren't just based in fluoroscopy alone. And so when we look at this, we can use techniques like ultrasound to be able to get value. Actually, I think there's a question that's popping up. Let me jump to that in just one quick second. Hold on a minute. Let's go here and go back to where we were before, and let's see if I can answer this question. So Elaine poses the question, do you need an MRI or just a shoulder X-ray, and how long does this last? So excellent question. So first, let me give you what I think is the general approach, and then I'll give you what I think is my own opinion. So the generalized approach is, I think you can be able to assess this via traditional X-ray, and people can be able to determine that, hey, you don't have something that's going to cause you a problem or issue that needs to be intervened immediately from a surgical standpoint. And so hence you may be a candidate for shoulder radiofrequency ablation. So you don't necessarily need an MRI. In terms of how long it lasts, and it depends on the type of treatment, as I referenced before. If you do radiofrequency that's thermal, if you do it via cooled, or if you do it via pulsed, I would probably hazard a guess 70 to maybe 90%, and that might be too far of a high estimate, but I don't think so, of most patients that are being treated with thermal radiofrequency, just because of the prevalence of the type of machines for thermal, which is the most common machine that's out there. And I would say on average, it's similar to what happens for the back. It can give you shoulder pain relief that can last anywhere from 6 to sometimes 9 months, but it can be repeated. Which brings me to a quick segue that I want to kind of jump on before those of you who are watching are saying, you know what, you've been talking too long. I don't want to hear all this. This ain't really the fit for me. So let me kind of get to this real quick. So what are the downsides to doing radiofrequency, which a lot of people who are regen advocates, which I happen to be, are very staunch in saying radiofrequency is the most horrible thing ever. And the reason why they say that is because when you target that nerve, they're concerned about whether that nerve has actual some degree of significance to providing and preventing atrophy of muscles that, although it may not innervate for motor function, it does help those muscles be more robust. So for instance, in the back, The area when you target that medial branch nerve, it can cause a problem with something that's called the multifidus. And that multifidus muscle is a muscle that provides structure. The same way as you'd have a girdle or support or back brace, that muscle can atrophy over time when that nerve has been treated multiple times over. It's something that we learned that was like, man, radiofrequency was being done to these patients over and over again, and they got pain relief, but they also got debilitated because we didn't have a concomitant physical therapy or activity status that was trying to be able to kind of balance that out, right? So when we think about the shoulder, could we potentially have that same possible outcome? Possibly. But the thing that I would say is, if you've been told, hey, we can give you value that takes you off of NSAIDs, takes you off of opioid medications, allows for you to be able to get your functional status back, why would we not put you together with an exercise program that makes you be more likely to not just stay at the level of where you started from, but how to be able to get you back to a more active state that keeps you where you would like to be able to be, and hopefully be able to wave off you needing a potential repeat radio frequency or multiple radio frequencies with continued consistency. 1. 2 is, let's say that we get your improvement. Why would we not thinking about then what else can we do? Not necessarily surgical, but might give benefit, whether that takes you down a paradigm of regenerative medicine treatment, down peripheral neuromodulation, down other types of avenues like cryo or other things of that nature, which we'll cover within the aspect of our channel in different contexts. But it helps you get to the place quicker and faster than you otherwise would be. So although you didn't ask this, Elaine, one of the things that I would kind of utilize within this is most people will say, well, how long does it take to even get to being able to get pain relief? If the doc is doing this similar to how you would do a medial branch block and a radio frequency in the lumbar spine, normally you need to have kind of like 2 initial diagnostic tests and then the final treatment. So on average, you're probably going to get there within a month's time frame. But most people's shoulder pain normally lasts longer. And yes, so you posed a question, I think, that follows right in that sort of segue is, do you start with a local injection first to see how it works? I think that is very highly dependent upon the physician. It's dependent upon the patient. And it's also dependent upon what you're doing from an insurance standpoint. But I would say most traditionally do. And I think that's a pretty good treatment option. Why do something that's an ablative technique or a technique that is going to be more invasive if you can be able to determine what's the likelihood of success? That local anesthetic doesn't always equate 1-to-1, but it sometimes can be able to say, okay, if I gave you local anesthetic and you got 70% of your pain improved or 90% of your pain improved, there's a pretty good likelihood that you're going to get benefit from doing a radiofrequency ablation. So one of the things that I kind of jumped ahead and was meaning to come back to is historically we use fluoroscopy. Like I said before, fluoroscopy, to kind of quantify this again, are things like this, where you can see under live x-ray the placement of needles that are at that site. But now what we're doing is not just where we think the nerve root happens to be, but to use it in context with the areas of ultrasound. So you're combining it with an ultrasound utilization where you can actually see the nerve. And you can target the nerve and use fluoroscopy and ultrasound in conjunction, similar to what we do, or those docs who use regenerative medicine in an effective way, similar to what they do when they say, hey, you know what? Okay, what we're really going to look to do is to be able to utilize these techniques to give us kind of this crosshair type technique. I can see it under x-ray. It gives me this kind of discrete pattern. And then what I'll do is I'll come back and I'll look at it under ultrasound and I can see where that nerve happens to sit. And so when we have that, it lets us be able to say, okay, we have really good confirmation of the nerve, of what's happening with it in relationship to the bone, whether there's vascular structures around it, because we can be able to identify that with ultrasound, and how we can get the best possible outcome and potentially use less thermal energy if we need to, and or less local anesthetic when you're doing the diagnostic treatment. So this is a quick summary of a shoulder treatment option that lets you be able to get value and pain relief, particularly without having to rely upon steroid treatment alone, which many times has a continuing diminishing returns. And the upside to this is that if it's done with conscientious thought, it's not going to cause long-term downstream effects if we're aware about the musculature and how to be able to make sure that pain is, after it's alleviated, it doesn't cause atrophy of the muscles when it's activated. I appreciate those of you who are joining me live, and hopefully this is a value to you and maybe be a value of someone else that might be watching this later. If so, send them out a link, let them know about it, and we do greatly appreciate you sharing this with us and joining. Again, videos are going to be Wednesday evening at this same time. Appreciate you so much for joining. Have a great day.